Thank you for watching this program tonight with the best physicians of the region. My name is Dr. Luis Munoz, and I'm the president of the El Paso County Medical Society. It is our hope that you will find this program informative and interesting. We at the El Paso County Medical Society invest in community education with our programs. I hope you will find this program very informative, with great medical advices and great medical information. Thank you again for watching this program tonight, and have a great night.
Hi, during this program, we are going to pay homage to the weekend sports warriors, and hopefully we're going to help keep all of us out of the hospital. We also have a lot of true athletes in our town who share common injuries with each other. And this panel that we have this evening is the El Paso Chihuahuas official team physicians from the El Paso Orthopedic Surgery Group. And they're going to be talking about common sports injuries, and we're here to hear some pointers on how to prevent them. And we're also here to find out what to do if we do get into trouble and harm ourselves. This evening's program is underwritten by Tenet, the Hospitals of Providence, and we also want to thank the El Paso County Medical Society for bringing the show to you each and every month. I'm Catherine Berg, and this is the El Paso Physician. Thanks again for joining us. Today, we're going to be talking about common sports injuries, and we have special guests with us this evening. We have the team physicians for the El Paso Chihuahuas, and it's so nice to have all three of you here. So we're going to talk a little bit about some of the games, but we're really going to talk a lot about what is so common, both in baseball, but really we're here for the general public as well, those of us that go out and golf, if we haven't golfed in a long time, and boom, there goes our shoulder, or we step off a curb, or there's soccer and you fall down. So we're going to have a really good show that I think is great for the general populace. I'm looking at Dr. Urrea because you are the veteran on the board here tonight. So thank you for joining us. And it's the first time that you've been in this studio, which is kind of nice. We've been doing this for about a year now. So Dr. Urrea is orthopedic sports medicine surgery. And so that's the title for all three of you guys, which is going to be kind of hard to differentiate you, right? Then we have Dr. William Arroyo, who is also orthopedic sports medicine surgery. And then Dr. David Mansfield, who I think you've been on the show before, but obviously you have not. You said, no, you haven't been.
Had not.
So I feel like I've known you forever, your family, and again, orthopedic sports medicine surgery. So on that note, Dr. Urrea, let's start with you since you know the routine.
Okay.
We introduced you, said what your title is, but what, if it's a little bit different from the other two on the panel, what is it that you do all day, every day, and what exactly does that title mean?
Well, as an orthopedic surgeon, you take care of injuries from your top of your head, of your spine down to your toes. And some of us, like in this panel here, we have done a fellowship training, an extra year, where we specialize in minimally invasive surgery, arthroscopy, particularly honing in the injuries of the shoulder, hip, knees, as well as the elbow and the ankle. And then it involves, whether it's ligaments, your tendons, your muscles, your bones. And that extra year that we did was we all worked with professional teams in our respective fellowships for that year. And we specialized in doing, the care of athletes. But that's a fun part of certainly what I do. I think we all agree with that. But the bread and butter of our existence, what we do is take care of people just like us.
Right.
We understand what the weekend warrior is. I certainly tried to do that for quite a while, but now I have to be more careful. But these younger brothers here are able to do much more than that.
They're not that much younger. I mean, well, he might be. But no, but that's nicely said, because I think that we all think that we're 25 in our heads until we get out. For example, I became an empty nester. And I had these rollerblades left over in my son's closet. And I thought, this is going to be fun. That happened fast. I used to be great. And then your body just changes. You don't realize 10 years later, it's like, it's not the same. Dr. Arroyo, how would you describe what you do all day, every day? And if it's the same, you can say same and then go on if you want.
Actually, I was going to mention something different. Like, I think what we do as a sports medicine doctor is completely different compared to other like subspecialties in orthopedics. Because we, like Dr. Urrea was saying, like we're taking care mostly of the community, but we have a second job.
Right.
Which is the sports medicine physician role. Like in this case, like with the Chihuahuas, or when we cover high schools or like UTEP athletes, we are assuming our second role as the caregiver for that community. Right. So we have our practice. We start clinic at 7 a.m. or 8 a.m. We end up at 5 p.m. And then we have to
go to a game.
Cover a game for 2 or 3 hours, like really dedicating that time to those athletes, to their needs, to their families, to their athletic trainers, to everyone. So it's kind of like interesting, like compared to other specialties that we assume that second role just because we love what we do.
Right. And that's going to be one of my main questions in a few moments too, is like take me down or, run through of what a game is, but we'll get to that in a second. Dr. Mansfield, how about you?
Well, I think, basically we all do the same things, but I would think what I'd like to stress about the way the three of us may look at the injuries a little differently than your non-sports medicine orthopedic surgeon is we really focus on the injury and trying to get the patient back as quickly as possible in a time frame that allows them maximal recovery, but also maximum
athletic
benefit
ability.
and athletic benefit. Yeah, because a lot of the times, sometimes a lot of people who don't do sports medicine are a little bit more conservative about injuries that maybe should not be treated as severely. So keeping a kid out of sports for 6 weeks for an ankle sprain, as opposed to talking to the trainer and say, hey, just manage with the trainer. When the trainer says you can go back and play, as opposed to having to go see the doctor every 6 weeks. And I think that's something we learned as part of our fellowship by working with the athletic trainers. Because I know that when I was an athlete, and especially in college and high school, to me, the trainer was just the coach that put tape on. But I found out that in my fellowship that these were, master level educated people that had gone through extra training and were very well educated and really understood physiology, the mechanics of injury. And so they're a huge resource that we have in our community.
So talk about and expand on that, because I know you mentioned it as well. What exactly is the fellowship? So you get your trained, you have your orthopedic training, and then knowing that you're going to be working with sports teams. I know last time we talked about the minors. I think you were doing football games for UTEP.
We all are.
You all are. So when you have that training, just to kind of explain to the audience, what does that require? Like what extra training are you getting? And are you doing that like on the job training? I'm assuming some of that's the case too, but explain that to our audience. Because I think they see you guys on the field too, and they're like, oh, it's some doc, or like you said, some trainer that put tapes on you.
So we all did 5 years of orthopedic surgery. And then after that, we were lucky enough, or we actually not lucky, we worked hard enough to be accepted into really really good extra training programs for another year. So we did an extra year of training. Just so happened that Louis was up in Vail, Colorado, and I was in New York City, and he was in Southern California. Southern California.
Hey, there's a song about that.
Yeah, I had USC stuck in my brain, but it was like South Carolina was coming out. So, but it's an extra year of training that does allow us to learn certain techniques that Louis will talk about as well, and Will talk about, because Will's had a lot of extra training that he wasn't even around when Louis and I were doing our fellowships. So,
but in the hip, but you can talk. But the fellowship, what it is, it's usually a 12-year program. 12 months.
Just feels like 12 years.
Feels like 12 years. As a matter of fact, my fellowship was one of the greatest years of my life, and it was so much fun. But we took it's where you specialize and focus purely on sports injuries. You get to where we worked at. We know the three of us have a unique training that but between the three of us, nobody in this town. And if you go to LA, that's where you're going to find this type of broad training that we've had in sports between the three different regions where we were in New York, Southern California, and Colorado. And, we took everything from NFL players to the U.S. ski team, the Broncos, the Jets,
Wow.
UCLA. I mean, it was a lot, the disabled ski team. I mean, you get to learn so much, and you also get to do research, and you're working with the people, our professors, who are state of the art.
Right.
And their foundations we're able to, do all kinds of procedures in the lab before we're doing them and live. And it's just a wonderful, it's a very unique investment in our time for our education to really focus on what we love to do.
Mm-hmm.
And then we got to come home and provide now the same type of care that we would.
Thanks for coming home.
It's we love it.
No, I mean, this is we've been doing this program for 27, almost 28 years. And I love talking about physicians that are now being trained here, which is great, but those that left and have come back home. So thank you for that. You were talking about, because he was the young one on the panel, right? Yeah. So now you mentioned the word hip. So I guess there's some kind of a different way of treating hips now. Is that correct? So let's go into that really quick. And then we're going to go into some of the specific injury questions.
Yeah, absolutely. So in my training, I was lucky enough to go into a program where they specialize in hip preservation. So hip preservation is minimally invasive surgery, arthroscopy for most part, that we are, doing different type of repair, cartilage restoration, labrum repairs, decompressions around the hip, tendon repairs, everything into a very minimally invasive way.
So you're using the word preservation, meaning that you're not quite at the point of injury, or you are at a point of injury and you're trying to save things.
Yeah, pretty much. Yeah,
from going bad.
It's someone that is probably, I don't know, a middle-aged patient with hip pain, and they have some wear and tear of the hip, but they're probably not at the point where they need a hip replacement.
I get you.
So I can help them with a more minimally invasive operation where I can help them restore the joint.
That could be me, my friend.
Give them function and improve the pain.
Okay.
Yeah.
And probably more importantly, he's not saying this, for those younger athletes that have hip injuries, that when I started and when David started, we didn't quite understand how to treat them. And what he can do now is prevent major changes and problems in the joint, in the hip joint, if they're treated correctly.
Yeah.
Okay.
It was back in the days, there was like a high incidence of like young people having hip arthritis.
Right.
And then when they look back, they start finding that there are certain things going on in the hip that can be actually prevented or fixed before, getting to the point that the patient requires a hip replacement. So that's kind of like what I do now, right? When I was in fellowship, every patient was between, 19, 25 years old.
Right.
But that's the fellowship. That's the type of patient that you get during fellowship. But now in Paso, my community, they changed a little bit. Now I get the 40s and the 50s.
Do you treat anybody who's female and 57?
All the
Just
time.
wondering, because
All the time.
I have scoliosis, so I have a hip that doesn't behave, and it hasn't been behaving for about a decade.
Yeah, but you'll be surprised. Like, I have, patients that age that they come and they were told you need a hip replacement.
Right.
And for some reason, they just don't want to have a hip replacement. They're very active. They play golf, they swim, they run. And just with a very simple operation, I can restore the function and potentially delay the need for a hip replacement.
So true.
I'm glad you guys are here today. What I'd like to do, and I think this is the fun part of the show that we don't get to do so often in medical shows, I would love to know what a day at the game is. And we can choose whether it's baseball, we can choose whether it's basketball, football. And I'd like to have just a snippet from each of you and maybe take a different sport. And so, David, I'm going to start with you.
So I'll do football.
Okay, perfect. Perfect.
I'll do baseball. Because we're in the middle of baseball season right now.
Okay.
So baseball is actually an interesting sport because, especially with the Chihuahuas, because they're one day away, a lot of these guys, from going to the big leagues. So these are real. These are real. The highest. Some of the highest caliber athletes in the world are actually here in El Paso. And I think people forget that when they see, it's just minor league baseball. These guys are, big leaguers. Almost everyone are potential big leaguers. So our usual day is we contact the trainer. One of us is in contact with the trainers every day, and they'll have us say, "Hey, we have an injury. Could you come by a little bit before the game and come see these guys? We need some help, managing some of the medications." So actually, because of the way baseball is, a lot of the coaches get injured as well because they're throwing batting practice, they're
Good
hitting,
point.
they're doing
Right.
things, they're out on the field getting run over by their players sometimes in some of the plays. So we treat the entire staff. So during the game, we'll be in the dugout around the game, watching, making sure everything goes well. For the most part, which it almost always does, you're basically dealing with a lot of musculoskeletal or overuse injuries,
Mhm.
which we will examine and start a treatment regimen with the athletic trainers, and that's baseball basically.
So you're coaching the trainers basically on what to do
No,
when you
the-
are not
the-
there?
the
Sometimes
coach,
the other
Or-
way around.
yeah, the other way around.
Okay.
The,
All right.
the trainers are they are expert at this, and what they're really looking for is confirmation a lot of times.
Okay.
And sometimes, we'll say, oh, you know what? Yes, he does have this, but maybe we need to think this as well. One of the other things that we have the ability to do that the trainers don't is order special imaging tests that they, this one probably needs an MRI now. We're at the point now where we, in the medical decision tree, we are able to take that next step, prescribe medications, do the other things that the trainers can't do. But the athletic trainers, especially at this level, again, these are people that are going to be big league trainers.
And
So-
these are unsung heroes. We never hear about the
oh
trainers.
yeah, they are
You know,
definitely.
Somebody,
Usually-
I'm
Go
sorry.
ahead.
No,
Yeah,
somebody
Dr.
we
Urrea?
worked with the last 3 years. She's now in the major leagues as a trainer.
And she was the trainer for Team Mexico in the Baseball World Series. So
Wow.
I would say the thing about trainers, and this is my shameless trainer plug, and I think this is one thing that's important. In Texas, if you have football, you're mandated to have a trainer in high schools. And I think it's important to realize that a lot of times in a lot of communities, many children, this is the only health professional that they will see
Oh
on
my
a
goodness.
regular basis. And I think
Yeah.
just remembering that in the trainers was such a powerful thing when I think about that all the time. So
Yes.
Yeah,
Excellent point.
I agree. Like sometimes we have young kids that they get like an ACL tear, right?
Mhm.
And then they probably have no insurance. So, we do the surgery, but they don't have money to pay for a physical therapist.
Oh wow.
So this
Right.
trainer will become
They're
the
physical
actual
therapist.
physical therapist. And, we guide the trainer, this is what we need to do. This is how we're going to rehab this patient. And then,
Right.
you just establish a good rapport with the trainer. You call them, every other day, see how the athlete doing. So we have a very tight connection with the
Yeah.
trainers.
And that's an excellent point because a lot of times when there is no medical treatment, and hopefully some of those grow up to be trainers.
Mm.
I shamelessly will tell you, I came from Germany. I was very, very tall and they thought, oh, she's a basketball player. Had never seen a basketball in my life. So immediately after I made the wrong basket on the wrong side, I became a trainer. And that's my view of trainers. It's like, okay. So that's why I'm loving what's happening right here and talking about the real thing. And let's take it to football because I remember some of the things that you were talking about last time we were on their show is minor football. If somebody gets injured on the field, then what? What is available? And I know different schools, different venues and facilities have different things, but from there, you're on the spot. And what do you do? Maybe there's a case study out there that you can think of when somebody got hurt. Do you take them then to the hospital? Do you take them away and try to treat them in the facility? How does that usually go down?
Well, football is unique and that, there's always a potential for a major injury. Every sport has that. Football certainly is one that's the biggest. And then the next one would be rugby.
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 Boy,
I mean,
yeah.
they're collision.
Oh, they're
sports,
yeah,
right?
they are collision
They're really not
sports.
contact. I mean, soccer's a contact sport, basketball, but collision.
Yeah.
So football is that unique that somebody can really have a major injury, and in every game, there's always one or two injuries that bother you. Sometimes there are none. We're very happy about that. And the name team physician. I mean, we work together to help the athletic trainers and the coaches all figure out what's going on, who's capable of returning to play or not. So we'll evaluate every athlete that gets hurt on the field. Sometimes somebody is on the field with a dislocated shoulder.
Right.
Maybe they have, their neck hurts or something, and we'll evaluate them right there with the trainer, make that decision. I can count on my hand maybe 4 or 5 times I ever had to cart somebody off and go to the hospital straight, and that's over the last 28 years. So
Okay,
it's
that's
not
good.
that common,
Yeah.
but, I mean, there's been the one that scared me the most was somebody who ended up having a spinal cord concussion, which means that they didn't damage their cord, but they were hit. We saw that, and both players fell, and they weren't moving.
Both of them.
Both of them, and of course, each team, like when we're in Division I football, we're very blessed to have each team has their own physician in football and their own trainers, but we help each other.
Mm-hmm.
And in this case, we were both out there, and ours ended up he couldn't move his legs or his arms, and I thought he had a broken neck and he had severed his spinal cord. Long story short is that was in the first quarter. At the beginning of the fourth quarter, here he comes walking in with a neck brace. Luckily, matter of fact, we were in Houston at that time at David's old alma mater, Rice University, and the neurosurgeon who happens to be one of their team doctors was there, and he was able to take that athlete straight to the ER. They got all the studies done, and remarkably, he didn't have any structural damage, and that's and he walked in. He still had a little tingling in his hands, but it was miraculous, and so that was a beautiful story.
And he recovered just fine. He was just
afterwards, he did recover. He did have something called little spinal stenosis, where the cord goes down. It's a little tight. Some people have that. In his case, he already had one injury, most likely because of that. He was very high risk. And so I remember talking with him, and as well as a spine surgeon, and he came back to me because he really wanted to play, and I had to talk to his parents, like we all do. A lot of times it's about talking
That's
to
a
parents.
good point. You do. You're talking about,
And then we discussed the risk benefits, and, the bottom line was, is it worth playing and being paralyzed for the rest of your life? And he was really smart. He ended up being an assistant, graduate student, and now he's coaching. I don't know what university, but he's somewhere. So
good for him.
He used that as a positive.
And I would say Louis is pretty modest. He also had to deal with a hip dislocation on the field, which is
that true? I forgot.
And it's funny because the players, he's still in the community here, he's a great guy, but you would never know that he had a hip dislocation.
So describe that injury. Like when you're saying, I hear of shoulder dislocation. What is a hip dislocation? And it's not like something you can pop back in the joint, I'm assuming.
Well, no, a hip's very different.
Yeah.
He fell just right where his knee and his hip were at 90 degrees to each other, and a big lineman fell in the back of in the small back. We only figured that out when we saw film, but it was the perfect way that the hip came out posteriorly. It's not the first thing you think about.
Ouch.
We went out there. He held his hip, would look like dislocated, and he said, "Don't move it." So we carted him off, and luckily, we had the emergency room. We went right to Providence. I just took him straight to the OR. We were able to reduce it. He had just a small fracture, and we were able to rehab him. And he came back and played the next season.
So pardon my ignorance. I'm trying to picture what you're doing in the OR. So
it's a lot of fun.
I'm
just. It's one of those things, like especially when you're a first or second year resident,
right,
in the ER. That's kind of your job, and it's a lot of fun. You have to get up on top of the table,
right,
and then you get to hold their leg, and then depending which way it's dislocated, you pull while somebody's holding down the pelvis, and you do a little maneuver. And unless there's a piece of, which with an X-ray would tell if there's a piece of bone, something blocking it, you'll pop it back in. And then a hip is something that it's like an elbow. It's in, it goes in, and they have instant relief.
And you have to do all that without falling and dislocating your own hip.
I am like bracing my hands under the table, like,
No, you're literally.
Yeah, well, you have to be, right? Because it's physical. Oh.
Yeah, sometimes they have to be sedated because, you really have to pull very hard.
Oh, tell me he was sedated.
No, he was sedated.
Dear
you have to pull very hard to get the hip back in place.
Yeah, a lot of grunting back there. So it requires some extra help in the room too.
Yeah,
absolutely.
It's definitely like professional wrestling in the middle of the operating room.
Exactly.
Yeah, no, it is. But we've had, we've had kidney lacerations, liver lacerations, knee dislocation, multiple shoulders, some elbows.
So let's talk about some of the most common and maybe for the general public, which is me. I don't play on any sports team. What are the most common sports injuries And Dr. Roy, I'm going to start with you because we haven't talked with you for a while. What is some of the common sports injury that you see just coming into your office? It's like in my head, I'm thinking ankles, knees,
So the way I see it, I classify into different categories. You have the young athletes and you have the older athletes, right? Like in my experience, I don't know with them, but in my case, for younger athletes, the most common injury is ACL injuries and shoulder instability, right?
And shoulder instability.
Yeah.
Okay.
Which is shoulder dislocations, right? On the older population that are still active playing sport, the weekend warriors, what I see the most is probably meniscus injuries, like meniscus tears,
right,
and rotator cuff injuries.
Okay. And on that, say they come in, do you do work on them immediately? Do you say, oh, that can wait till Tuesday? And because I'm assuming they're coming into the emergency room. They're hopping around or...
Yeah, I think so. I mean, it depends of the, I would say the mechanism of injury and the type of force that are required to cause the injury. Like he mentioned knee dislocation, right? So when you have someone that dislocates the knee, we look at that model, like that means
let's play with this model.
That means that pretty much like when they have a knee dislocation, you have the collateral ligaments that are torn. You can also have like the ACL and the PCL ligament are torn. So technically the knee just comes out of place. But when that happens, we have to think about all the nerves,
right?
All the vessels that are behind also on the side that they can be injured, they can be lacerated.
So is it locked out of place? Like when you say that it's locked out of place until somebody goes in there physically.
This is a knee dislocation. So technically they come to the ER like this.
Oh. Okay.
The leg is crooked. They have a lot of pain. You can imagine all the vessels are not being compressed.
Right.
So you actually have to be very careful and just really watch these kids when you like put the knee back in place. So this is an emergent situation, right? This cannot wait for Monday, right?
Right.
That has to be done immediately and most likely in the operating room.
So in the operating room, so when you're doing this, is it just physical maneuver with your hands? Or you're actually going in there and incising something to when you say operating room, how are you getting in there and physically moving it? So in the hip, you said you're on top, you're moving everything into place. Same thing with the operating room on a knee?
Absolutely, yeah.
You always have to go in there.
Yeah, you have to go in there. Okay. And mainly you want to be in the operating room just in case something else happened, right? Like he mentioned the hip dislocation reduction. When I was a resident, I had a case where I had a hip dislocation. And when I tried to reduce it, I broke the femoral neck, right? So from being a reduction now becomes an operation.
Gotcha.
The good thing is you are already in the operating room, so it's easy. You have the setup to move forward and take care of the situation right away.
Okay.
The same with this, right? So let's say I do a reduction and then the blood flow is compromised to the leg, then we might have to do something else. We're already in the operating room, so we're able to manage.
And you can tell immediately if the blood flow is compromised at that point.
I can tell.
Okay.
Yeah.
Okay. And then when you're looking at nerves too, because I always think to myself, nerves are something too that we don't think about until you're in that situation.
Absolutely.
And nerves are tiny little.
Are very tiny nerves.
So how do you, I guess you just see it manually, correct? And I do want to bring up just, you talked about orthoscopic, and in general, the Da Vinci. I know that there's operations being done in all kinds of different ways. 20 years ago, it was a lot more heathenistic, if I can say that. But if you were going to do this type of operation, how would it be different now than it was 10 years ago?
Well,
since you're the young guy in the panel,
I think, maybe back in the days, in order to perform like a reconstruction of this ligaments, it required what we say an open approach, right? Where they will perform open incision, big approaches to get these ligaments reconstructed. Now with the new technology and the new advances in sports medicine, we can do all this reconstruction with just minimal incisions, less pain, less exposure, probably most better outcome.
So Dr. David, you said, So explain maybe the procedure of going through a surgery
one
like
thing
this.
I was going to say real quick is I know this is all the exciting stuff we see, but I think a lot of what we see, and especially we're seeing now in kids a lot more, are the overuse injuries because they're playing volleyball all year round and they're becoming super specialized athletes. So they don't ever stop their sport and go to another sport, cross training. So there's a lot of overuse. And that's, we were asking about what I see mostly. Probably that's the most thing, especially in the weekend warriors crowd. You see the overuse, you see the muscle injuries, things like that. as far as the arthroscopic, back to your question though, the arthroscopic, the way you'd address this is, there's a lot of different ways. That's a really complicated injury, but if just on arthroscopic things in general, generally what it entails is making 2 small incisions, one for a viewing portal, one for a working portal, to go in there and look at what's going on in the knee, and then from that you can address a lot of issues from those 2 incisions. Sometimes you have to make other small ones to make different, what we call portals, different entry points to the knee to move things around.
And how do you see what's happening in there?
There's a little camera.
Okay.
It's basically, I guess it's like a camera. It's a camera. It's a small camera with a tube that's about 4 millimeters in diameter. So you go in the knee and look inside the knee with fiber optics, and that's definitely one of the things that technology has allowed us to do, as opposed to making the big open. So it's basically like when people have the laparoscopic surgery, they have the I'm sure you've had them on with the Da Vinci and things like that. The camera, same type of technology, just the camera's more handheld. And we have a bunch of tools that we can use, some shavers, some arthroscopic like biters, resectors, things that allow us to do things. And then based on the damage we see, sometimes it's a ligament that's damaged, we have to reconstruct the ligament. So we may have to harvest the ligament sometimes from this tendon here or this tendon here.
See, this is the stuff that I love talking
Wait,
about.
sorry.
Yeah.
I guess you got to see this.
Yeah.
Sorry.
Yeah.
This tendon here and this tendon here. We harvest and can make, so we have to reconstruct or make a new ligament. Then when the fun part comes in, we use the power tools. Then the drills come out. They have to drill through the bone to anchor the tendons inside the bone. We make a bone tunnel, put the new reconstructed ligament into the tunnel, hold them with either a combination of screws, or there's some other fixation devices we can use. Most of the screws now, again, talking about technology, most of the screws now are what we call bio incorporating. They become bone over time, as opposed to back in the olden days when we first started, it was just metal screws. That's all we had.
Exactly. Right.
So, we talk.
And when you say harvesting, so are you taking part of this tendon and then regrowing it, for the lack of a better way of describing it, or are you just replacing it?
So what we do is we'll take like the middle part of this tendon here. This is called your quadriceps tendon. It's where the quadricep muscle attaches to the patella. And so we'll take the middle part of this tendon and then we can sew up the remaining part, and it'll grow back and fill in and heal. And then using that little strip of tendon, what we can do is we can make something that kind of approximates this ligament right here.
Okay.
And through drill a hole through here and a hole through here, and replace that ligament with the harvested tendon graft.
Okay. So let's talk a little bit about physical therapy. And I'm just because it's your turn, but anybody can take that. So when you're looking at this type of an injury, and I'd really like to get to shoulders in a moment too, when you're looking at a knee injury, because you cannot be mobile without using your knee, what is the physical therapy that goes around that? Throw out an approximate amount of time. I know everybody's different. I get it. Every injury is different. But just in general, let's throw something out about physical therapy.
Well, we use the most extreme injury. We're talking about a dislocation. But for knees, if you have a dislocated knee, it has to be emergently reduced.
Okay.
As far as fixing the things, it's a little different. You have to, depending what's wrong, if they have a locked knee, but let's just talk more simple things like an ACL.
Okay.
Which is still,
because that's really more
ACL
common.
is probably the biggest injury most of us that occur here in our community, not a dislocated knee. But the most important part is when to operate. And you never operate right away. You have to let the knee calm down, need inflammation to decrease, regain their motion, regain their quadriceps function. If you don't do that, we know that people then have a high risk of developing a very stiff knee, which we call arthrofibrosis, which is a very difficult complication that takes a long time to recover from.
Is that the scar tissue?
That's scar tissue, and you get stiff and everything. So the most important part is timing it correctly.
Okay.
And everybody wants to get back sooner than later, but sometimes it takes a couple of weeks and people get their motion. Most people take a little longer. Some people take 6 to 8 weeks and get really stiff. And then a few of those people that get really stiff, they have so much scar that things do heal. Those are unusual. So the timing of it is very important. And that's where we use the physical therapist to work with us, and they can rehab and bring that knee back. Now, if you have a dislocated, let's say the meniscus, which is this little blue, in that case, it's white, but these blue little wedges between our bones, those are kind of their shock absorption. They help with articulation and some stability. But if those are flipped, those you have to be faster in putting it out. But if it's torn, again, you want the knee to calm down. Same thing with the ACL. So it's important that we time it correctly to avoid a bigger complication. And all injuries all people heal a little differently, have different inflammatory events. So there's not just a common, but I'd say an ACL 2 to 4 weeks, sometimes 6.
Okay.
If it's a shoulder, if it's a dislocated shoulder, that can be, you're not going to jump right away. No, if you have somebody who's young, a traumatic dislocation who plays a collision sport or is a thrower, you're going to take nowadays we know that the first time dislocator should be operated on to minimize their complication later on and the risk if they keep dislocating other people. So there's not any important thing, but and there's not a time frame that's perfect, except if you have a dislocated shoulder, if you have something dislocated, it has to be put in right away.
Right.
And then I think the most important part is after surgery, we have to respect biology. The body remodels, it heals, remodels, and it takes different things. And we have good studies now with ACLs or with cartilage that what used to have what it's called accelerated rehab back in the 90s, that we were pushing it too much and people were getting re-injured too quickly. And now we're better about that.
So letting the body do some of its own healing. We got to let the body, because like what David explained, you've taken a graft, right?
A quadriceps tendon, put it into where an ACL does. And what's beautiful about that, the body sees that ligament and says, let's make a tendon out of it. And it uses the collagen and everything else, but it literally goes in and starts replacing all the different fibers and cells and covers it with synovium. And when you go back and you do some ACLs, let's say they had an injury later on and you look at it, it's hard to tell that you did an
biology fairies in there.
It's beautiful what the body can do,
Yes.
but you need to respect the biology of things.
Interesting.
And so faster is not better. And that's,
right.
And kids, unfortunately, they're kids,
right.
know, and everybody wants to get back sooner, but that's where they can really make a big difference. And like an ACL, the average NFL player takes about 10 and a half months to get back to playing.
Wow, that long.
Level.
So that's an entire season.
There was a guy, Adrian Peterson, you may remember him or not, one of the greatest for a small amount of time. Matter of fact, he came and played at the Sun Bowl one year. But he came back at 8.5 months and everybody thought he's Superman. And then he re-injured it.
Yeah.
So you have to respect that. And the same thing with the rotator cuffs, and I'll let them, I don't want to.
Let's talk about rotator cuffs, because is that the one that it's the only one in our body that really does the rotation that it does, right? More than any other.
Yeah. So I want to use this one. So the rotator cuff is pretty much composed of 4 different tendons. Right here in the front, we have the subscapularis tendon. And that tendon, what it does is just rotates your shoulder internally.
Okay.
Right. Then you have on top, just next to it, you have the supraspinatus and infraspinatus. And the supraspinatus, for most part, you just do a lateral motion of the shoulder. And the infraspinatus and teres minor, they also do some elevation, but also external rotation. Of the shoulder. So like I said before, I see this injury is very common. It's probably the surgery we'll do probably the most in the middle-aged population, like just rotator cuff tears, either playing sports, people that fall, older patients that they've been having, maybe they started with a small tear and it was really not symptomatic. And over time, they're just developing more pain and dysfunction, right?
Right.
A lot of pain. So when they come, they have big rotator cuff tear. So, this is probably one of the surgeries that we do the most.
So when you say this, and this is me just wanting to know what it is that you're doing in surgery. So it's a tear, and you're not suturing it, or are you suturing it? Are you? Oh, look.
Yeah, so I think we can have a lot of debate on this because I think me and Louis we do the same type of surgery. Mansfield might do something different, but it's all the same pretty much. So let's say
show it to this camera.
So let's say we have someone with a tear like this that involves the supraspinatus and infraspinatus. So that patient is gonna come with pain with lateral motion, pain at night, weakness, and a lot of pain on the shoulder. So what we do, especially we're talking about arthroscopic surgery. This is one of the surgeries that back in the days, it used to be a big open operation.
Oh, yeah.
Then they went to like mini open, and now we are arthroscopic. So in my cases, I literally perform like 3 little, like I want to say poke holes, like one in the front, one lateral, and one in the back. And actually the camera is probably a little bit thinner than this pen.
Oh my.
So you can imagine, like we're looking inside, and even that this is like 4 millimeters, what we see inside is like 10 times the size of what it really is, right? So we have the ability of like using these small instruments and actually put like suture anchors. And now with the technology, like he mentioned, now we can use anchors that are made of calcium. So in like 2 years, they become
So it's like you're stapling calcium in there? Is that, I'm just trying to.
We use a point of fixation. It's like a little screw.
Like a drywall anchor.
It's
like
a drywall anchor, right? So we put those like right there at the margin of the footprint of the rotator cuff, and we have different instruments that we use to pass sutures through it. And in our case, we just suture it down.
Gotcha.
Pretty much.
Okay.
Yeah.
And like arthroscopy, it's amazing. Like the shoulder or the knee, you can see more with that little instrument than when you open up the shoulder and knee. I mean,
and how long have we had that technology?
Oh, well,
a decade?
I started, no, that technology, when I started, when I did my fellowship in 96, 97, we were doing that for knees, and shoulders were just starting to do. Where I trained, it was one of the places and where we would do arthroscopy, look, maybe drill the at that time there were little metal anchors.
Right.
And to me, what the greatest thing now is the sutures. Back then you had to be so careful because they were weak. Now the sutures, you don't even worry about it. And that's something that I learned, because you broke one, you had to take out the little screw. It was very difficult. But back then, and then we did the little mini open, we look inside, and then within 2000 we were doing, I mean, when David came to El Paso, 2002, we were the only 2 doing arthroscopic rotator cuffs, bank carts, all kinds of stuff. And, most orthopedic surgeons know how to do an arthroscopy to diagnose. Not as many are able to do everything under the arthroscopy. And then Dr. Arroyo doing, the hip that, I mean, we didn't even do those kind of surgeries open. And now it's doing some incredible reconstruction and recreating the normal anatomy.
So here's my question. We have about 15 minutes. I want you guys to think about some stuff that we haven't talked about yet that you do want to talk about. But one of the things I love doing on this program is talking about what's new and what's next. And I know that there are a bunch of studies that we talked about years ago that were happening in Europe that are now happening here. But in general, in this world of sports medicine, orthopedic surgery, et cetera, what's on the horizon that you wish you could do right now, and maybe 5 or 10 years from now, we're going to have the ability to A, B, C, or D? And I'm just throwing that out to anybody who wants to take it.
I think
Dr. Mansfield?
I think one of the things that I think is on the horizon, I think we're going to really start. There's a lot of information coming out, but also a lot of interest in is the cartilage restoration. So,
good point.
right now, it's advanced a lot, even since I started. When I came back in 2002. There was a procedure called the genzyme reimplantation, or you harvest some cells, you go to the lab. Back then you had to grow them for like 12 weeks, and then they bring them back, and you would open up, and replace it. So this is when I say regenerate. So this is the shiny. I tell people there's 2 kinds of cartilage in the knee. There's the articular cartilage, which is kind of the shiny end of the chicken bone, and there's the fiber cartilage with those discs that Louis was talking about earlier. So a lot of times the shiny of the chicken bone, this articular cartilage gets these defects right here. And so that's basically what arthritis is. When people say, oh, you went into my knee, did you scrape out the arthritis? And I said, well, I can't, because it's like tire tread. You can't just scrape off more tire tread and expect to have the tire tread gone. I mean, regenerate. So what we would do is we would harvest some of this normal cartilage here and then grow in the lab and then open it up and then fill this in with articular cartilage or the new cells that were grown in the lab, with the hopes that they would regrow the cartilage. And
these are the cells of the person who's having the surgery.
It's your same, yeah.
Okay.
And so it was an effective procedure, but it was really time consuming and laborious, because you would have to take a patch of what we called periosteal patch from further down on the bone. It's like the lining of the bone. You'd have to cut this patch out. It'd have to be measured perfectly. Then you'd have to sew it with really like 6-0, like fine sutures, like the suture they used to do like heart surgery with.
Oh, wow.
Yeah, it would take forever. And so now they've got different ways to deliver it, where it comes impregnated into a like a wafer that has the cells in it. So you just kind of put it in there, and you can just use some biologic adhesives, for lack of a better word, that keep it in place. And so I think as we're moving towards even better technology, we're going to be able to start using technology to fix the fibrocartilage, the meniscus, instead of having big gaps in there now, we can just put it in there, maybe put a suture in and sew it in. I think that's, in 5-10 years, I think that's my hope, is that we're going to get there, because I know there's a lot of hope with like stem cells, but stem cells are great because they have the ability to reproduce. The problem with stem cells is they don't have the physical structure. So like a lot of these problems it's not just a biologic problem, there's a physical problem.
Right.
So you have to correct both of them. And right now we're just, by putting stem cells in a bad knee, we're putting the cells in, but we're not letting the scaffolding that's necessary to let them do their whole job.
Yeah. I think one of the advances that we are seeing now, and I think I've been one of the few that are doing this in town, is about the ACL surgery, right?
Mm-hmm.
Like we've been talking about reconstructing the ACL, taking like a quad tendon, patellar tendon, and use that to replace what the ACL used to be.
Mm-hmm.
Now we have a new technology that we're calling the bridge enhanced ACL restoration. So with that, what we're doing now, instead of having to harvest and reconstruct the ACL, what we're doing is repairing the ACL. Right? The patient's own ACL that is torn, we do a repair. Back in the days, that was a very common surgery, just doing an ACL repair, but the environment inside the knee was not allowing that ACL to heal, because we have all these enzymes inside the knee fighting for, destroying the repair of the ACL.
How often do you hear that? You have all these enzymes inside the knee fighting for. I mean, that's something we don't hear about, talk about at all.
So now with this new technology,
I want you to show that to the camera so they can kind of see
so with the new
environment.
So right now inside the knee, we have a lot of enzymes. So the knee is a compartment. It's surrounded what we call synovium. It's like a knee inside a balloon, right?
Mm-hmm.
So you have water. The water is just inside the knee. So you can imagine inside this balloon, you have all these enzymes that were, they cause inflammation, they could cause like tear and wear of the cartilage. So now I think with this new technology, we're able to repair the ACL, and we have a little device. It's like a little sponge made of collagen. And what we do, we put blood inside that sponge, the patient's own blood, and then we put it right in front of the ACL. And what that does, it actually protects the ACL from the outside environment. And at the same time, it provides a blood supply to the repair area.
And that's a permanent.
Yeah, so the implant will dissolve.
Oh, I see.
But by the time it dissolves, the ACL is already healed. So now we don't
talk
have...
about biology again,
so
right?
It's all biology. And we are really respecting the biology, because we are repairing the ACL. We're putting an implant that has whole blood in there from the patient to heal his own ACL. And then there's no need to harvest. There's less pain, less swelling after the operation.
I'm thinking, as we're talking about this, all the guys in the lab that are helping out with this process, right? And we talk about the surgeries and everything that's happening here, but in the lab and all the research that's going on, which is kind of in that same venue, We talked about stem cells probably a decade ago.
Mhm.
We were talking about what's going to be coming up. And I think that we were talking about backs at that time and discs in the spine. Where are we with that in this day? I know we're not really talking about spines, but I feel like that's one of the first places that we're looking for cushion.
Yeah.
Biology, lab, cushion, happiness to help repair people.
We're, whether it's spine or knee or whatever, the research in biology is trying to identify the cells that allow for repair.
Mm.
So stem cells are, they're the cells inside mostly our pelvis bone or our femur. There's very few of them, but they are capable in the right environment with the right scaffold, something to repair bone, cartilage, whatever.
Mm-hmm. Mm-hmm.
And a couple of years ago, Dr. Draga, who is a fellow at STEM Hawkins, but now he's at Stanford, they've discovered the mother stem cell. So you got the stem cell, then the next lineage that does create cartilage. That's the first time they've identified. Now what they're trying to do is figure out how do we identify that in our own body? Because we can go in there, when you talk about stem cells today, it's hit or miss, and it's mostly
Right.
miss to get,
Yeah.
you get a lot of other positive proteins, enzymes, cells, but the stem cell, and we don't know what they're doing, but they're trying to research. And I do believe David hit on the spot, whether it's 5 or 10 years, but I do think in our lifetime, certainly in Dr. Arroyo's lifetime.
You're older, so you
I
don't
may
know
not.
that.
No, hopefully it's going to be used on me, but we're going to be able to identify how to identify that stem cell that's yours,
Mm-hmm.
harvest it. Then we have to learn how to stimulate it in the lab.
Mm-hmm.
And then what's real important is you don't want a stem cell just to grow, because that's called cancer.
Oh gosh, exactly.
So
it's a whole controlling situation.
The way I look at it is we're going to be able to identify cells, be able to inject it in the knee. Let's say have cartilage damage. You go in arthroscopically, take care of what's broken. Cartilage is that's the hardest thing for us to take care of.
Mm-hmm.
And if you can't get it fixed, you're in high risk for arthritis. So you go and you clean out, you inject this stem cell, and then we're going to understand the biology of it and how to activate it and how to slow it down. And there's a lot of research, and we're nowhere close to that.
Yeah.
But it's every year there's more and more data.
Yeah.
We all go to the sports medicine society conferences, and there's always subsection talking about the orthobiologics of things. So
It's
we're
always
there.
fascinating to me, all the new stuff that comes to this table every time we do some kind of an ortho show. On that note, we have like 5 minutes. And since you're young and you're new, is there anything we haven't talked about that you want to throw out there before we wrap up?
I think we covered almost everything. We covered
Okay.
what we do as team physician. We covered new advances in orthopedic surgery. We talk about what we do, and
Okay,
talk
bye.
about everything.
Have a nice
Yeah.
day.
Well,
Dr.
I'm
Mansfield?
going to put a shameless plug in for Will, and I think Will's kind of downplaying what he actually brings to our community. I mean, the way something is as common as a hamstring tear, which basically
That
ended my
happens a lot.
soccer career basically because I didn't take care of it correctly. He has the ability to treat hamstring tears of varying degrees with much more effective techniques than we had before. So,
And do you do that surgically? Do you go inside?
So pretty much it's kind of like a very kind of funny operation because technically, the hamstring is literally in your butt, right?
Right.
So I had the patient like facing down on the OR table, and basically I just do like 2 little poke holes in that area of the glute, and I kept going in just with the camera, find the tendon, and just do like a repair.
So when you
Right.
say do a repair, I'm thinking sewing.
Yeah, the same,
Okay.
very, very similar repair when we
Okay.
talk about the rotator cuff surgery. What is good about this surgery, the sciatic nerve.
yeah,
is
that's the
lit-
thing is he makes it sound so easy, but there's a
Yeah,
giant
so
nerve right
that's
there.
why people are afraid of doing this surgery.
Well, you hear sciatic nerve and all of a sudden that's a
Yes.
whole nother show.
So literally the sciatic nerve is like 2 centimeters from the tendon. So we're talking a very
wow.
short distance. So
Okay.
what used to happen when in the past they used to do them open, and with open, dissection bleeding, sometimes it's very hard to see the sciatic nerve. And even if you identify the nerve, you do the repair, the amount of scar tissue that can develop is massive in that area, and then it can scar down to the sciatic nerve, and then they can have symptoms from it, right? Now with this technology,
And that won't go away.
well, you
Could
can
that be
go.
a
Well, you
permanent-
can go back and do releases, but you're always
Right.
compromising
Right.
the sciatic nerve. So in this surgery, I can through the camera, I can identify the nerve. I know what it is. I can work around everything else without actually being close to the sciatic nerve. And I have done few of those in town. I don't think there's anyone doing those endoscopically in the city. And I even have people from Alamogordo, Albuquerque, just coming here because they
It's called
they want to get
hamstring
that surgery.
tourism is what it
Yeah.
is. Mm-hmm.
So
It's
it's
Very
pretty
nice.
amazing. Pretty amazing what we can do now. Yeah, for sure.
it's amazing trying to when you have a good athlete with who's very well built, and they have it's when the hamstring's torn off the bone that we're talking about.
Yeah.
And I remember just trying to just get exposure. It's a very difficult surgery, and what Will can do is it's amazing. Arthroscopy, it looks like a rotator cuff, but let me tell you, the anatomy, everything else, it's.
I think it's just I'm happy, like, in the place in my career, like when I came back to El Paso, I was gone for college and residency and medical school and fellowship. I was the guy that brought in the new stuff that nobody else was doing. When Louis came back, he was the guy that brought in the new stuff that nobody else was doing. And so now I feel like, happy that
You're passing the
we have the
torch.
guy
Yeah.
who's bringing the new stuff, keeping it going. And so just bringing in a skill
Thank you,
sets
Dr.
that we
Royer,
don't
for
get.
being
Yeah.
that guy. No, it's been an absolute joy. I love doing this program. And Dr. Rhea knows this. It's just been because it's so practical. There's so many things that we talk about here that everybody has issues with. So thank you so much. We've had Dr. Louis Urrea. We've had Dr. William, everybody calls you Will. So Will Arroyo and Dr. David Mansfield. And again, this is the El Paso Orthopedic Surgery Group that we're here, who is again the official team physicians for the Chihuahuas. And we want to say thank you very much to the hospitals of Providence and Tenet for bringing this program to you. And if you didn't get a chance to watch all of the show, or if you want to watch it again, along with any other show that we produced over the last several years, you can do that in several areas. The first one is pbselpaso.org. Just look up the words, The El Paso Physician. You could actually see that on that website. Also, the El Paso County Medical Society at EPCMS, and that one's a .com. Or, like many people do, and all of our kids who are addicted to YouTube, you can go to YouTube and type in The El Paso Physician, and usually you can just slash whatever the show is. This one's called Common Sports Injuries, but anything that we do, you can go back and watch any of those programs. So thank you so much for watching and paying attention and listening, and thank you. I'm hopefully that I will try not to get hurt. So again, you've been watching The El Paso Physician. I'm Catherine Berg. Good night.
Good evening. I am Dr. Allison Days, a past president of the El Paso County Medical Society. If you have questions on tonight's topic, please reach out to epmedsoc@aol.com, and we will try to get your questions answered in a timely manner by an expert in the field. A big thanks goes out from the Society to all of our specialists who have been able to give their time as speakers on this program, and to the El Paso community members who have welcomed us into their lives for all of these years. Thank you again for tuning into the El Paso Physician tonight.